As we move into stage C, the recommendations for acute therapy once heart failure has ensued. There was consensus regarding furosemide therapy, so this loop diuretic that we discussed, given either IV or IM at 2 milligrams per kilogram, followed by 2 milligram per kilogram dosages, IV, IM, or sub-Q hourly until there was a fall in respiratory rate and effort, or a total of 8 milligrams per kilogram were given over 4 hours. It was also a consensus recommendation that a continuous rate infusion of furosemide at 1 milligram per kilogram per hour after an initial bolus for life-threatening pulmonary edema was also a reasonable choice. This has been shown in people with heart failure and has been shown to be effective in normal horses and normal dogs at increasing diuresis as compared to intermittent boluses of furosemide. Furthermore, in stage C, consensus was reached that for the acute treatment in the hospital, that pimobendan at 0.25 to 0.3 milligrams per kilogram orally every 12 hours should be administered. Consensus was reached by this group also involving the use of oxygen via a humidity and temperature-controlled cage or incubator, or via nasal cannula, as you see pictured here. So oxygen therapy was recommended as consensus. In addition, abdominal paracentesis or thoracocentesis was advocated to relieve effusions which were felt to be sufficient to impair ventilation or cause distress to the patient. The acute therapy of stage C heart failure also received the following consensus recommendations from this panel. It was suggested that optimizing nursing care with the appropriate environmental temperature and humidity, elevation of the head higher than the thorax and the legs, and placing the sedated patients in a sternal position, all to enhance respiration efficiency and comfort, were ideal. Secondly, sedation or anxiolytic therapy for those animals that are very dyspneic and anxious with narcotics such as butorphanol or buprenorphine with acepromazine was useful. For stage C, no consensus was reached for the use of ACE inhibitors. So a majority of the panelists felt that an ACE inhibitor such as enalapril or benazepril was useful here. This did not reach consensus of 100% recommendation. We do know from the study shown for you here, the IMPROVE trial published in 1995, that in acute heart failure, that ACE inhibitors, as you can see, do produce a fall in the pulmonary capillary wedge pressure. That's the driving pressure that gives you pulmonary edema. And you can see that at 8 hours, there's a statistically significant improvement in the pulmonary wedge pressure in dogs who received enalapril as compared to those that received placebo plus standard therapy. So we do have proof of efficacy of ACE inhibitors in the acute phase of stage C heart failure, but the panel did not reach a recommendation. As we move into chronic management of stage C heart failure, the panel reached consensus on the following: furosemide, 2 mg per kilogram every 12 hours, or as needed to maintain patient comfort. ACE inhibitors, for example, enalapril or benazepril, given at 0.5 milligrams per kilogram every 12 hours, and pimobendan at 0.25 to 0.3 milligrams per kilogram every 12 hours. So this triple therapy was agreed upon by all 10 panelists as the ideal way to treat heart failure in chronic stage C patients, meaning patients with heart failure or a history of heart failure, but who are able to be treated at home. We have a lot of evidence of the use of ACE inhibitors in heart failure. You see before you clinical trials, all placebo-controlled double-blind trials, the LIVE trial, the BENCH trial, and the FIRST trial, which looked at enalapril, benazepril, and imidazopyr. And the first two showed increased survival in both dogs with mitral valvular disease and dilated cardiomyopathy when compared to placebo. In the imidazole trial, it was now well accepted that ACE inhibitors had a benefit, so it wasn't considered to be ethical to compare imidazole to placebo. So you can see then in that chart that imidazole was compared to enalapril, and there was no difference between the curves showing all-cause mortality. So we know then that the harmful effects of chronic RAS activation have been demonstrated in clinical patients, and the benefits of ACE inhibition have been shown, both with chronic valvular disease and dilated cardiomyopathy. The QUEST trial, which looked at pimobendan in mitral insufficiency, looked at 260 dogs with mitral valvular disease of moderate severity. All these dogs were in congestive heart failure. And here you see the Kaplan-Meier survival curve showing patients which received pimobendan plus standard therapy as compared to the ACE inhibitor benazepril plus standard therapy. And what you see is the median survival was actually higher in the pimobendan treated group, 267 versus 140 days as a median survival. This difference of 127 days or 4 months was statistically significant. No consensus was reached for stage C chronic heart failure by this panel in regards to spironolactone. However, the majority of the panel felt that this drug was useful in the chronic management of heart failure for its aldosterone antagonism effects, but not for its diuretic effects, which are relatively weak. It's notable that spironolactone is approved for therapy of heart failure in Europe. It's also notable that the consensus panel made its recommendations prior to publication of the article that you see before you. This publication in the Journal of Veterinary Internal Medicine in 2010 indicates the efficacy of spironolactone in the treatment of mitral valvular disease. The dosage has also been determined for spironolactone by studies carried out in Europe in which aldosterone was infused into normal dogs and the ratio of urine sodium to potassium was evaluated. And you can see from this chart that the efficacy of aldosterone antagonists, in this case spironolactone, was maximized at 2 milligrams per kilogram. This then is the dosage of spironolactone, meaning that it should be administered once daily at 2 milligrams per kilogram, and this has been documented both in clinical cases and in the study you see before you. The use of spironolactone in treatment of heart failure in people arose from a study called the Rawls trial. And you see a chart from that study before you in which spironolactone plus standard therapy was compared to placebo plus standard therapy. And you can see that these two curves diverge widely in this group of about 1,600 patients with severe congestive heart failure. The study had to be terminated early because there was such improvement in the treatment group that it was not considered ethically to continue the study. We now have data in dogs with mitral valvular disease receiving spironolactone, and what we see is that of 221 dogs, there was benefit not only in a composite endpoint, which included congestive heart failure death, euthanasia for heart failure, and severe worsening of mitral valvular disease-induced heart failure on your left. There was also significant benefit in those patients treated with spironolactone as compared to control group in this placebo-controlled double-blinded trial looking at cardiac-related death, meaning dogs who died of heart failure or were euthanized due to severe signs of heart failure. So spironolactone as an aldosterone receptor blocker does appear to be efficacious in the dog as it has been shown to be in people. While one cannot say for sure, it is possible that had this manuscript been published prior to the consensus panel's report, that there would have been a consensus on the use of spironolactone. In any case, there was certainly a majority recommendation for the use of this drug in chronic stage C heart failure in dogs. In summary then, the ACVIM consensus panel gave the following recommendations. And what I've given for you here is the ACVIM method of evaluating cardiac disease in the dog with the consensus recommendations on the bottom of the slide and the majority recommendations, meaning those that reach the majority but not consensus recommendation on the top. And what you can see is that for the asymptomatic heart disease, those at risk, those with disease but no enlargement, and those with disease and cardiac enlargement, that as a consensus recommendation, the only thing that was recommended was to educate the client. However, the majority of panelists felt that ACE inhibitors were beneficial in B2, those dogs without failure but did have cardiac enlargement. Also in that group, the panel recommended mild sodium restriction. As we move into those dogs who've already developed heart failure, group C, you can see that for acute management in the hospital, furosemide by some route, IV, IM, sub-Q, or possibly by continuous rate infusion, pimobendan, oxygen supplementation, sedation, as I've already discussed, and the possible use of vasodilators such as nitroprusside and inotropic agents such as dobutamine, neither of which, by the way, is approved for the use in the dog, might be recommended. Finally, thoracocentesis and abdominocentesis were recommended in a consensus manner. I would like to point out that in the acute management of heart failure in the hospital, that the majority of the panelists felt that ACE inhibitors would be useful. As we move on then into chronic treatment of heart failure patients, the majority of panelists felt that there was, the consensus recommendation was that furosemide, ACE inhibitors, and pimobendan be used. But in addition to that, the majority of the 10 panelists felt that spironolactone should also be used. Finally, in the refractory treatment of heart failure, furosemide IV, possibly in a continuous rate infusion, ACE inhibitors, pimobendan, oxygen, ventilatory therapy, sedation, and more aggressive reduction in afterload with drugs such as nitroprusside or amlodipine would all be useful. After those dogs go home, the use of furosemide, ACE inhibitors, spironolactone, and pimobendan were all advocated as consensus recommendations by this panel. You can see that sodium restriction begins then in asymptomatic patients as mild reduction in salt intake. As we move into heart failure patients, moderate, for example, senior diets are advocated. And finally, in refractory heart failure, moderate to severe salt restriction was recommended by this panel.